Thank you. This is your hostess for this day, Bhavita Singh. We welcome all of you to the International Association for Adolescent Health, 11th World Congress on Adolescent Health. Well, our mission is to focus on improving adolescent access to healthcare. Well, today we have the opportunity to learn and share from the vast body of experience. Yes, we have national and international experts joining us today to fulfill our sole purpose. Ladies and gentlemen, now taking this further, yes, we'll be beginning with our first session. But before I invite a dignitary on stage, it gives me immense pleasure to thank Ministry of Health and Family Welfare, Government of India, because without their support and engagement, it wouldn't have been possible to organize 11th World Congress here in India. So can we have a huge round of applause for our Ministry of Health and Family Welfare, Government of India. And now I would like to invite on stage Mr. Manoj Jalani, Additional Secretary and Mission Director, National Health Mission, Ministry of Health and Family Welfare, Government of India. So I request you to please come and join me on dais. Welcome, sir. It's truly an honor to have you here. And now I would also request Professor Susan Sawyer, President, International Association for Adolescent Health, to please join me for our first session. And now I would request our session chairs to please take this session further. Thank you.
Thank you, Bhavati, and a very warm good morning to you all on behalf of myself, the President of the International Association for Adolescent Health, and my co-chair, Mr. Manoj Jalani, as we've heard, the Additional Secretary and Mission Director of the National Health Mission, Ministry of India and Family, Ministry for Health and Family Welfare of the Government of India. A very warm welcome to you all. We had our formal opening last night, so I'm not going to be trying to repeat all of what was shared at that wonderful lamplighting ceremony. But there are 4 brief points that I would like to make. They are about time, place, purpose, and partners. And this first session of this meeting is very much focused on pulling these themes together. So in terms of time, as we talked about last night, we are at peak youth. The success of the Millennium Development Goal era has created the largest population of young people from 10 to 24 that the world has ever seen. And in terms of timing, for the first time ever, we now have a global policy context in terms of the global strategy for women's, children's and adolescents' health that is catapulting adolescents from the margins of global health to centre stage. There could not be a more important time to be hosting this meeting. What about place? Nowhere is there a more compelling case to be made for adolescent health than in Asia, home to half of the world's adolescents, and to India, home to 1 in 5 of the world's 10 to 19-year-olds. I come from Australia, where we have a total population of 25 million, and I still find it gobsmackingly astounding that this country that we are in today has 253 million adolescents that we are needing to empower in terms of their future lives and protect and support to have the best possible outcomes. I find this extraordinary. With the Government of India significantly investing in a policy framework to support their healthy development, the excitement of holding the International Association for Adolescent Health World Congress here in India couldn't be clearer. So, time and place. My third point is purpose. 30 years ago, the founders of the International Association of Adolescent Health were ahead of their time in forming an organisation that was global in its scope, multidisciplinary in its orientation, and actively engaging young people in terms of helping to create a vision to improve the health and well-being of young people across the world. IAAH has held a World Congress for the last, over the 30 years of existence, every 4 years. And this meeting provides an important opportunity for the field to review the scope of adolescent health, which, as I mentioned last night, is so much wider than clinical medicine, as important as that is, to review the latest evidence. And in this meeting across the next few days, this is absolutely what we will be doing. This lies way beyond narrowly defined traditional academic disciplines, and it is fabulous to have such a scope of players here. We need to be urgently considering how to take interventions to scale, and there is obviously no country that matters more so than here in India. But the last point I want to make is in terms of the importance of partners. Few parts of the world are yet to fully embrace this notion of a field of adolescent health. And that's not just in low and middle income countries for whom this feels a much more recent phenomena. Our colleagues in Europe are equally struggling with this phenomena. This meeting is about, as much about us really trying to establish this field of adolescent health. And in terms of that, we are needing new partners, new players to pull this field together. And at this meeting, I must say, we have never before, firstly, had so many of you. We talked yesterday about there being over 1,000. The most recent update is that we now have over 1,100 participants. Thank you. This is clearly by far and away the biggest meeting that IAAH has ever held, and you are from over 65 countries from every region of the world. You represent UN agencies, you represent community-based NGOs, you represent academia, you represent social and philanthropic organisations. You are researchers, educators, community leaders. Many of you will be parents, and many of you, 125 of you, are youth delegates, and you are here to be helping to co-create your futures, helping articulate to us as adult members of this world, what do we need to do differently to make the world a healthier place for your generation and the generations of young people to come. So we are here this morning. We have time, place, we have purpose and partners. I'd like to get this conference going by introducing Dr. Anthony Costello, if you can come and join the stage. Anthony, I'm so pleased that you are able to join us here. Anthony is Director of WHO's Department of Maternal, Newborn, Child and Adolescent Health, and has been in that role for the last 2 years. And I must say, there could not be a more exciting time for you to be at the helm of WHO's department, given how much is happening. Prior to this role, Anthony has an incredible career where he was Director of University College London Institute for Global Health, Professor of International Child Health, with a stellar track record in academia in relationship to community development with mothers groups in particular. So welcome and thank you.
Thank you very much. It's wonderful to be here. I said, why is it that India runs such great conferences to Dr. Sood? And she said, because we know how to run weddings. So we heard yesterday that adolescents are up to 1/3 of the population, yet we forget. All of us, well, not in this room, but outside, they forget all about them. And we've heard about the need to create an adolescent ecosystem to ensure that adolescents can fulfill all their potentials: physical, cognitive, emotional, social, and the rest. And I left you yesterday with some thoughts about some of the areas which we'll touch upon in this conference. And I just want to say a word or two about 3 of them, and then go on to talk about what I think is the great holy grail, which is evidence-based implementation at scale. So let's start with that. We shouldn't be afraid of lawyers, nasty lawyers and nasty economists, because we've got to engage with them. You know, for example, just one example, the taxes on sugar-sweetened beverages, which I think is very important, and now 26 countries have adopted taxation on this to address consumption, one component of the obesity crisis, but only one. This is a systemic problem. And then, of course, in Europe, we have to face reality that there have been astronomically high youth unemployment rates. 50% in Greece, 30% in Spain, and many other southern states. Why? In my view, because of a crazy austerity economics and because of the ridiculous valuation of the euro. And this is about economic policy. I know, I'm from WHO, I'm not supposed to talk about politics, but I think you guys should be able to, and we should question when people are allowing these unemployment rates to be so sky high because of crazy economic policies. Enough said. Right. On the community front, I was fascinated to learn about RKSK yesterday, and I've been reading up a lot of the stuff they're doing, and I think this is the biggest adolescent program in the world. One issue is whether we're thinking about instructing adolescents or having conversations with them, and I think we have to get the balance right there, and I'll say a bit more about that in a minute. I learned from the Lancet Commission one thing, that adolescents basically love two things. They live for two things. One is their peer groups, and the other is for their mobile phones. And this is great. I mean, I appreciate that. And I think we need to therefore capitalize on both of those. Now, I'm interested in human groups. This is the Robin Dunbar classification, that you go from your survival clique, your family, and there's a tripling of size. And I'm interested in sympathy groups. I've just finished a book on him, so I'll probably try and sell it to you next year. And it's the science of sympathy groups, the sympathy group being the smallest social grouping beyond your family. It's your choir, your church group, your credit group, your forestry group, your book group, your football team, etc. And I've been interested in this for about 20 years, and we've done a lot of work, as some of you may know, on maternal and newborn deaths and women's groups, and this was a big study that we did in Nepal, which showed the value of getting people coming together to solve their own problems. We've done 7 more well actually 9 now, 2 more in India in fact, randomized controlled trials, looking at this in a large population. And what was interesting was that one of the trials didn't have any impact. And it's very important to have negative data to know when things don't work. And we realized when we analyzed this study why it didn't work in Bangladesh. We didn't get the numbers right. We didn't get the coverage right. And so we repeated the study and we showed an impact when we increased the coverage. And it shows you that you need to know the conditions for anything that you do to have impact. And it's led on to a WHO recommendation. But I think we need trials of wicked adolescents. I say wicked because wicked problems are ones that are very complex to solve, like obesity, like climate change, like physical activity. And I think to tackle wicked problems, you need wicked solutions. And a wicked solution is the creativity of a group. So I think one of the things I would love to see much more of at scale is looking at the way in which adolescents interact and come together to solve problems. Now, on the health service front, I think we've lost the idea of a social hospital. This is a picture of Siena Hospital in 1450, and you can see a surgeon on the left, the hospital committee behind, a friar on the right doing end-of-life care, a dog and a cat coming in to make people feel happy. So a very social environment, and in this picture of the fresco by Domenico de Bartoli, you can see a women's group on the left who are wet nurses breastfeeding abandoned orphans, and on the right you can see one of those orphans, now an adolescent girl, being betrothed to a local man and reintegrated into society. So this is a very social environment, and hospitals have totally forgotten about that. And this conference, par excellence, is about reintegrating the social into our kind of technical biomedical view of life. So here are my tips, very brief tips about how to do evidence-based implementation at scale. I liked this tweet actually. I-development, the idea that the solution to an economic, political, social, or humanitarian problem is to build a website. And I'm not anti-websites or mobiles, I think they're fantastic, but I think there is a bit more to life than just being on your mobile phone. Anyway, so the first principle is being country-led. Everything should be run, actually in India it's state-led, because most states here are bigger than most countries. And it's only people that run their own affairs that really understand the context. And so bringing in ideas from outside only works if you've really got that kind of country leadership. Secondly, ownership. Whether it's clinicians in a hospital, whether it's adolescents themselves, they need to be totally engaged in this, not just consulted from time to time about ideas imposed from above. And so I think ownership is my second principle that you must build in, and again, how to co-produce health, to use a trendy term. Social accountability, this is an Australian social accountability group for a hospital. I can't see Susan Sawyer there, but this is an old photo. I think this was taken Australian fashion, I would say about 5 years ago. So, but social accountability is extremely important, and we need to remember that citizen participation is vital to success of our programs. Next, systems. There's a lot written about being a systems thinker. If you want to deal with obesity or other things, you need to think in a very much more complex way, and I'll let you look that up on various websites. There's no money going into adolescent health. Look at this analysis of aid into everything. There's not even a category for adolescent health. It's that 1/3 of the population that's forgotten about. And the job of this conference is to go out and tell the rest of the world they're all wrong. They've got their principles all wrong. This is the place to be. This is the future. And if you're going to deal with a systems problem like physical activity, you're not going to do it by telling people to exercise. You've got to have spaces to exercise. You've got to have a culture of, you've got to have cycling lanes. I cycle all the time in Switzerland. In London, you dice with death. You know, so, I mean, this is important. My next principle, team up. Well, I've said that. We've got to have groups. We've got to bring people together, whether it's clinical groups or community groups or adolescent groups. We've got to think about both equity and evidence. Without data, you're just another person with an opinion, said Deming. So we mustn't be afraid to collect data, whether it's quantitative or qualitative, and particularly looking at marginalized populations, like this population in Jharkhand, India, from where we did one of our trials. We need leadership. There's loads of leaders in this audience. I can see lots of them. In fact, most of you are leaders. I put one picture up of Anuradha Gupta, who's now at Gavi, but she was the permanent secretary, who very much led, I think, a lot of the developments on adolescent health in India, and was a very inspiring person. Whenever I ran into her in a lift or a meeting, she was always telling me about adolescent health. So we need people like that. And on the right is an MP from Malawi who I thought was very dynamic and made a lot of things happen with our women's groups. We need learning networks, whether it's training systems, working with adolescents, or indeed through websites. This is the WHO website that my colleagues devised based on all the work they did with UNICEF, UNFPA, all the agencies, and loads of other people. So David Ross, Valentina Bultag, Kit, and others helped to devise this. And I like it because it's really simple. Even I can use it. So you go in and press one of those color buttons, and it gives you a list of things you should think about doing. We need operational science. We need to look at what's happening. I can't wait to come back and look at the RKSK program, because I'm sure this is massive, and I'm sure it's got all kinds of problems, but that's the fun of doing this. You get out and look to see what's working well, what is working less well. And finally, we do use mobiles occasionally at WHO, not very often, but accountability, and accountability is not just monitoring, it's monitoring but then reviewing and acting upon the information you get. So those are my principles, and just to remind you of them here, it's quite a long list and it's quite difficult. We must remember also that WHO, UNICEF and UNFPA have a lot of materials that you can use, but with 65 countries here, this is an international movement and we need to tap into all of that. And to help you remember all of this, this is actually my email address. So costelloa@who.int is an acronym for you. So you can actually remember these principles. You don't have to write them all down. If you can't remember any of them, there's this fantastic documentation from the Iaah framework, and of course the Lancet Commission, which is a brilliant document that George and Susan and others led. So you can go to those as well. I'd like to thank everyone here for organising this conference. India is a wonderful place because deep in this culture is the haircut. And if you go and have your hair cut in India, you get the best scalp massage in the world. Indian culture. Thank you very much.
I was making a note of the various themes you wrote, not realising that you'd summarised so beautifully at the end, Tony, so thank you. Those themes that you've raised are clearly all of the themes that, for those of you who have had a chance to look at the program, will appreciate, will be explored over the next 3 days. And I must say, I think that this is probably the opportunity to acknowledge, as I did last night, the very capable leadership of our program, the International Scientific Committee, that's been chaired so ably by David Ross from WHO and Professor Pierre-André Michaud from the University of Lausanne in Switzerland. If you could join with me in not only thanking Anthony again for his fabulous presentation, but in terms of the program that we will be having over the next few days. Thank you to you too. I can see David in front of me. I can't see Pierre-André anywhere here, so my apologies, Pierre-André. Okay, where? There he is over there. Thank you, Pierre-André. To the Indians in the room, Sunil Mira, where are you? Please do come and join us on stage for our next presentation. Because to the Indians in the room, Dr. Sunil Mira needs absolutely no introduction, a practicing paediatrician for the past 30 years. In 1990, Sunil established MAMTA Institute for Mothers and Children, which commenced as an organisation working with the most underprivileged communities in an urban slum in this city of Delhi. Since then, it's expanded to an incredibly large organisation. The last count was about 400 staff, is that right? 860 staff. Many of them who have been working in support of this meeting here today, and I would also like to acknowledge all of them. But in terms of the organisation now, it's one that has helped forge partnerships, create networks and actions that advance political commitment, investment in health and rights of the most marginalised. MAMTA now has an increasing focus on adolescent health, sexual and reproductive health and rights, communicable diseases including HIV and TB, and increasingly on non-communicable diseases. And I would just like to acknowledge, prior to Sunil sharing the past of the Indian context with us, bringing us up to this point, that this meeting simply would not happen without him as an individual, as well as without the amazingly capable team behind him. So thank you to you all.
Thank you so much. I'm a bit nervous, and let me be honest, right? To begin with, I'm going to take forward what Anthony said. Anthony, you hit the nail. I have 2 daughters, and I married both of them. And both of them had an audience of about 1,000 people. So I had an experience to hold such a meeting. That's why you were right there, that Indians have experience of doing marriage. And my 2 daughters might be in this hall also, who could stand by this. Thank you for touching that subject. Taking it forward, many of the things which Anthony said may be re-spoken, but more in context of India. And I am glad that he touched upon many of the issues he has spoken, because those are some of the learnings we want to talk about in Indian context. Yes, it was in early 90s is when we thought about adolescence. Very difficult to talk about adolescent in that stage of the development that we were in India. We first established the adolescent development centers in urban slums of Delhi way back. It was 93, if I recollect that rightly. And doing that was a tremendous experience in terms of saying, why are we doing that? And I think, I must tell you, it gave us a significant learnings in early 90s, that by supporting adolescent networks, there was no evidence, mind you, at that time. It was simple logic science. And I'm not talking about literature at that time. It was just the gut feeling that we needed to do that, was to create a supporting environment and create adolescent networks, and at the same time, also help them in increased mobility. And these 3 things were done in 93, 94, And we were not a researcher group, we were pure interventionists. And what we thought we got out of that was something which we said was it increased school retention, it improved their career aspirations, and it increased access to school and health services. All this in next 2 decades became more evidence-based science. And what was experienced in '93 was pure logical science, which I need to say, we need to move on. Science will come, science will follow, and we'll go on changing our pathway as the evidence builds up. With this background, let me take you through what has changed in the last 2 decades in the Indian context, and also in terms of how we responded to it through policies and programs in last 2 decades. And lastly, few learnings as have been put forward by Anthony very appropriately. First slide. I need to operate from here. Okay. We all know the numbers. Yes, we are 253 million, but we have changed from 85 and 61 to 253 million. That's the load that has shifted. We have said yesterday, I think Madam Secretary said that the adolescent literacy has shown a significant shift. We are almost 90% of them in school, and the gender gap is narrowing down. Equal number of girls and boys are coming to school now. In terms of certain facts and figures, the profile in terms of currently married, I think we have been talking about this again, that we have seen a significant decline, but still significant number of them are married, almost 27% as per the NFHS 4, National Family Health Survey 4. The age-specific fertility rate has shown a significant decline also, but still happens to be hovering around 30 or so. But something which we need to talk also very significantly is the shift that we have seen over the years in terms of number of reported cases in 10 to 18 years. And I think we strongly believe that this surge that's being seen is also because of, not only because of, is also because of increased reporting of cases that's happening. At the same time, the suicide cases are showing an increase. It's showing a significant increase in the last 1 decade. And I think we need to take a serious count of that this is increasing. And this is also about just the reported cases. Very quickly to take you through some figures, very quickly. Contraception is still low. Nutrition, I think the double burden of anemia and obesity is a challenge. I think we are increasingly threatened with the epidemic of obesity as much as we have not yet addressed the need of undernutrition. Anemia still, as Dr. Paul said yesterday, is still above 50%. Don't forget boys, please. Boys also have a significant component to contribute to it, and they need to be looked as much. Mental health, very recently we have started reporting on it. We are seeing prevalence almost 7.3. Tobacco use, significant, 9.6 on reported cases, but I am told it is showing a decline in the last 3 to 5 years. Injuries, violence are starting to get reported, mind you. We are starting to know about them, that we have almost 22% of adolescents who face physical or sexual violence. As my friend Chandra says, many of us accept in our marriages that slapping is part of love that the husband gives to the wife. It's amazing that we still talk like that. Annually, 22,000 deaths happen because of accidents. It's important to emphasize this, that these are many of the causes which are preventable, and prevention is something which we need to look at if we need to look at how we address the adolescent mortality issue, which we always tend to believe is a healthy subset of populations. Some voices, I think I want to talk about just these voices to talk about the comparison. In our intervention program, as I've been saying, in 2000 we captured few voices, and I tried to pick out some voices in 2018. The difference is that empowerment is happening, the source of information is changing, and at the same time, barriers are shifting for adolescents. And this is something which we need to understand, what this shift means to us in terms of our programming as we move forward. And these adolescents are telling us what should we be investing in and how should we be working with them to take it forward. In terms of actions, India used to have, or probably has moved beyond it, 5-year action plans. I still remember in 2000 going to Planning Commission office and saying, we want adolescents to be reflected in 10th plan. 10th plan, 11th plan, 12th one were the policy documents which drove what the line ministries used to do. And I do recollect in 10th plan, we made it a point that the Ministry of Youth Affairs would take up this component in its line items of Youth Affairs Ministry. But honestly speaking, Ministry of Health, sir, even at that time was reluctant to take on the issue of adolescent health, sir. That was in 10th plan I'm talking. In 11th plan, I think we came much ahead. It was at this time when the adolescent health, adolescent sexual reproductive health, I think we had a wonderful RCH, reproductive child health two-phase beginning, and we had an opportunity to position adolescent reproductive sexual health and rights. And that was the time when we strengthened and started talking about secondary education as much, and we started talking about how we bring them together. But it was actually in 12th plan that you see that it got into overall growth and development, and it expanded more in terms of the secondary school educations. And this is when I think we started connecting education first time to early pregnancy and child marriages. And I think that's where I think we got more thrust moving. And I think some of the NFHS data we see is a reflection of what we could talk about 2012. I think Dr. Paul said something very interesting from the Niti Aayog yesterday, that we need to have indicators for 2022. And it tells me that we don't need to stop at 2017. And sir, my concerted request to take it forward in terms of what we discussed yesterday to indicators that we could drive from 2017 to 2022. And since the Prime Minister made a concerted effort to all of us to make 75 years as a time when we could have a flagship component of adolescent, as Anthony said, this is time now to invest in this age group, and he showed that the resources were practically not present for this particular age group. A bit about health policy. I won't go into the track record. I think our recent national health policy is a wonderful document to look at. And I think it's a reflection how we have incorporated adolescent health within the universal health coverage, within the quality health care, engagement of private sector, preemptive care interventions. And I think school health program intervention has been very critically and smartly spoken in the youth in this health policy program. And expanding SRH beyond the domain of SRH, not forgetting it, but extending it further to the nutrition and psychological challenges of the adolescents. Education policy 2016 is in drought stage, but I think it's talking the right thing. It's talking the right stuff. And we need to understand that we had school-based population education programs when I was in my medical school days. I'm talking about 70s. They were there, but seems to be not having effectively intervened and seems to be not having effectively carried forward to reach where we have reached. It's talking about counseling. I think it's good to see that we are talking about counseling within the school system and making it mandatory for the underachievers and others. I think the important element that has been added and significantly enhanced and upscaled is the midday meal. That has been invested in a big way, and we are increasing the contribution per adolescent for midday meal so that we could get to the better quality of midday meals in our schools. And mind you, one of the reasons for improved school retention has been the midday meal program. So we need to do it well, and we need to nurture it well so that we don't have those data of anemias, undernutrition, and obesities if we do this well with 90% of them in schools now. Earlier we always used to say they are dropouts. They are in school, so we could do it well in that setting. Our national program, I'll just touch about the AEP program or the adolescent education. In 2003, in partnership with UNICEF, we created a national education program, which was primarily very much in line with comprehensive sexuality education program. That was the time when HIV was big. Many of you in the room would understand. And it allowed us to bring in the comprehensive sexuality education very significant into the program, but we had a backlash. For right reasons, wrong reasons, no comments. But we had a backlash, and we had to dilute that program. And today, I stand today to say it is important for us to revisit our adolescent education program to be more comprehensive in adolescent sexuality education. They are asking for you. Many of the sessions in this Congress will give you evidence for that. Ma'am touched upon yesterday on Save Girl Child, Save Educate Girl Child. That's the Beti Bachao program. I think this is a very important flagship program of the government. We need to see that it happens well, it goes well. I like this line of this, ensuring girls are born nurtured and educated. I think it's critical for this country where the sex ratio is still a big challenge, and I think not just when they are born, they need to survive, thrive, and empowered to a point that they're able to they're as good as anybody else in the society. Convergence is being spoken about, but we are still too far to achieve that in an effective manner, but it needs to be done and needs to be carried forward. Coming back to the adolescent health, IRSH, as it was called, the Adolescent Reproductive Sexual Health Strategy, was brought in 2006 and 2007. It has the components as stated. But one mistake I think we did was at that point of time, we concentrated a lot on services sector. Into the establishing more clinics, we were a bit weak on our community empowerment processes. And I think that's what we have addressed when we moved to RKSK. Sabla was again a program which was very effectively taken on, but again, the connect between Sabla and IRSH was extremely difficult to establish. And it was a community-based program addressing the adolescent girls, reaching out to adolescent girls, and was done in limited number of the district. I understand that is going to be scaled up in the country. National AIDS Control Program. The National AIDS Control Program again addressed the issues of youth and vulnerability. But the big challenge was, how do we reach schools and colleges? And I think what was created at that point of time, being part of that process, was youth-friendly information services. And Dr. Khera being here, he would recollect how in NACO these services were established. But again, the challenge was the connectivity between the primary healthcare services and these services. Rashtra Kishore Swasthya Karyakram, I'm not going to touch too much about this. I know Sir is going to talk about this also, but at the same time, I just want to say that one component in this, which has been the most debated one, is the peer education component. I think that has been debated. We need to talk a lot about this to say, what does it mean in our larger program? How do we see that this is a cog in the wheel rather than the wheel by itself? What is its limitation? What is its scope? And how much and how far can it reach in addressing the needs of the adolescents? I'll very quickly go through this component of key approaches. We have gone through these 6.
You have 1 minute.
Okay. I think we had these 5 key things, the key approaches we had. I think these were 5 approaches we did well over the years. The challenge was how to integrate them, how to bring them together, and how do they work in one district or one province collectively. Lastly, some of the learnings and way forward. I'll take 1 minute extra because I thought in the beginning we took more time. Learning and way forward. It's time for us to turn spotlight on adolescents. I think the point that was being raised by Anthony was our states are the drivers. We don't want only to be confined to the center. I think we need to get, and states are present here in this meeting, we need to get this spotlight to state and to the district and provincial level. The second, at the policy level, I think it's the core competencies to deliver both in public health and in the clinical services. I think we need to emphasize that. The clinical services also need that kind of the core competencies. We need increased financial and human resources, as has been stated already. With changing epidemiological, we need an intersectoral approach. We need an approach which addresses accidents, violence as much as it addresses pregnancy and the fetal outcomes. And contraceptive use. Yes, it was emphasized yesterday by Dr. Paul, we need age and sex desegregated data, and we need honest and rigorous evaluations of our programs. We need to build evidence in live environment. We need implementation science and research to happen concurrently while our programs continue. We need to intervene early, and we continue to intervene. Science is telling us, development science is telling us, brain development is telling us, we need to intervene early and continue to stay invested. We need to encourage innovations. We need to have low-cost innovations and technology with the human resource constraint that we have. We need to connect the two and see that these innovations are connected. Above all, it's time to question ourselves that are we reaching the adolescent who actually need us more than others? Are we reaching the high-risk adolescent, the adolescent key populations, and adolescents in high-risk settings through our existing programming? Thank you very much. Sorry if I took long. And I want you to keep this slide.
My partner in crime, thank you, Sunil, but we are keeping this show to time, as you know well. Gogonlajong Faladi, please come and join us on the stage. Gigi, as she is known, is our next speaker, who is a young person who is joining us from Botswana. Gigi is passionate about transforming lives and believes that a world free of poverty, with equity and dignity, is possible only with greater engagement of the voices of the young. Having been actively engaged in advocacy and philanthropy since she was 5 years old, and I do need to get the gossip about this. I hope we'll hear about it now. She is a youth ambassador, a human rights activist and advocate, a former radio host, writer and poet. Currently, she is a political science student at the University of Botswana and a board member of the Global Partnership for Maternal, Newborn and Child Health, where she heads up the adolescent and youth constituency. And perhaps just before inviting her to share her voice with us, I would like to take this opportunity to thank the many, many funders who have contributed to this meeting, because the 125 young people, of whom Gigi is one, are all here thanks to the support of our donor community. So if you could please join with me in thanking them. Gigi, over to you.
Thank you very much, Suzanne, for that introduction. I think one thing that a couple of people don't know about me is that I'm also a farmer. So about 3 years ago, I was doing an outreach at a village that is not very far from our capital city, and I had actually organized a workshop for the farming community there to build that capacity on how to move from being subsistence to commercial farmers, and also doing some public education on food security. One of the farmers told me that her daughter had just given birth, who is 13 years old, and would not tell them who the father of the child is. I was shocked, and I advised her to seek assistance from social workers for guidance and counseling. I also advised her to ensure that her daughter visits the nearest healthcare facility to get information and access to family planning methods. 2 years later, the daughter was pregnant again, now at 15 years old. The first time, she was not able to access the services because she was deemed too young to receive such information or commodities. One of the challenges we face is that of either not reaching adolescents, those who are marginalized geographically or by disability and other barriers, or reaching the ones that we have in schools and in urban settings when it is a bit too late. This is because, to a large extent, we still treat adolescents as estimates and their issues as assumptions. We also lack in aligning current interventions to current challenges and emerging trends in the lives of adolescents in order to safeguard their future. Adolescents are not only central to everything we want to achieve, but are also central to achieving it. Thus, it's not only about delivering better for adolescents, but also delivering better with adolescents. So in doing so, I have summarized my 6 key action points, and I made sure that they fit into the 10 minutes I've been allocated. The first one is political will and commitment. We must strive to motivate political will and commitment at the highest level to propel investment in the health, education, and well-being of adolescents. Instruments such as the Global Strategy on Women's, Children, and Adolescent Health should be aligned to our national development priorities to stand a chance for implementation. It is indeed not enough for a child to survive if we're not able to create an enabling opportunity and conducive environment for them to thrive, transform, and indeed realize their full potential. It's not enough for a girl child to survive birth while she faces the risks of being married off when she's 10 years old or being subjected to harmful cultural practices. When we invest in adolescents, as all the other speakers have said, our country stands great chances of reaping the demographic dividend. When we ignore the needs of such a large majority, we will have an army of angry, disempowered, and frustrated youth. Adolescent health is a critical sustainable development priority area that we need to get it right from the beginning. And ladies and gentlemen, let us understand that political will and commitment is not just in signing human rights treaties and attending high-level meetings. It is in increasing national budget for the health sector. It's in having adolescent and gender-responsive policies and programming. It's in strengthening the healthcare system in your own country so that even you as a leader is good enough for you and you're not a party to medical tourism. It is in harmonizing laws and breaking down barriers in your country to deliver better sexual reproductive health and rights, especially those that are related to protecting the girl child. The second one is on data, and I won't elaborate too much on that as other speakers have already eloquently talked about the need for data. But all I can say is that we say in God we trust, but in programming we need data. What is not counted does not count, and what is not known does not receive the attention that it needs. Human rights, and especially sexual reproductive health and rights, are just way too important to be left to assumptions. 3 is governance. Governance is often an ignored component of development, yet it is a major enabler. We can have the best human rights treaties and mobilize great support for delivering on health rights, but these cannot move when the country has major governance deficits. A girl child having much greater chances of being married off at adolescence than completing school is not just an issue of traditional religion, but a reflection of governance deficits. High prevalence of gender-based violence is not just an aftermath of patriarchy, but it also largely goes unaddressed because of lack of political will and governance deficits. And it is important to ensure that we undertake gender audits of policies, strategies, and programs, and ensure they espouse transformation to benefit both, or all genders rather, and not only recognize but institutionalize ending gender-based violence. The fourth one is inclusion. We need to move more towards inclusivity and closing inequality gaps. And we must really strive and make deliberate efforts to reach the people that we tend to say hard to reach. I find it rather interesting and problematic that in all our countries we have the population that we call hard to reach population. But when we go to these localities, you will find a bottle of soda. When you go to these hard to reach communities, you will find political campaign merchandise. And sometimes it leads me to wonder, are they really hard to reach, or are we simply not prioritizing to reach them? The fifth one is to young people. It is indeed true that we must be the change we want to see, because we have to organize effectively or agonize miserably. As I always say, as young people, if you don't have a seat at the table, we need to dress comfortably to sit on the floor, because at every course, we have to be engaged and be part of the conversation. As youth activists and young development practitioners, we carry the voices of the most marginalized and voiceless, but also the hopes of being heard and seen with a promise for a much better future. We cannot let ourselves and our constituents down. The sixth and the last one is on innovations. Young people are actively innovating, coming up with solutions, but lack the capacity to launch them and scale them up. We need to support these solutions that enhance service delivery, access to information and services. Sometimes what we need is not necessarily a new cure for ailments, but perhaps we need to cure the way in which we work. I find something interesting in my country that agricultural demonstrators from the government go to the cattle posts, the farms and rural areas to give the cows the bolas. But we don't have healthcare workers who do such outreaches to immunize babies. Also in my country, you find the Department of Road Transport and Safety and the police send you messages when your car has been flagged or when you need to renew your vehicle registration. But we don't have a healthcare system that sends messages to remind you to go for testing, to go and get your medication, for all of that. I work with young people who are so active and want to innovate and want to change the world. One of them recently designed a glove, and this is for the community of people living with disability. And what happens is that if you don't know how to communicate in sign language, the person who signs puts on the glove and then they will sign to communicate what they want to say, and then an audio is going to come out of that glove and communicate to you so that they can access services. The other young people have designed bot systems that help in information dissemination, realizing that across Africa, data is so expensive, but Facebook is so cheap and in other countries it's free. So instead of designing a new application, why not have that information accessible inside Facebook? Others have been able to design health commodity management information systems, because we have commodities that expire, we have commodities that don't reach the people on time, and this is a system that is ICT based and gives you real-time updates on commodities across the whole country, from even the smallest health posts. These are innovations that are coming from young people, and they're waiting for you to come and say, let's partner and work together and see how we can do this to enhance delivery of information and services. So in conclusion, let's ask ourselves the most important question at gatherings like this, which is, how do we move the conversation from these cool air-conditioned rooms and ensure that it results in impact on the ground? Dialogue on mapping the plan is always very important, but we should speak beyond rhetoric limited to conference rooms. We each have to make a decision daily that we will play our roles in safeguarding a better future for adolescents. Every day when the sun rises somewhere in the world, we celebrate the birth of a girl child. But also every day when the sun sets, that same girl child faces the challenge of either being married off or ending up as a teenage mother. Every day, we are accountable for the girl child who misses classes because she has her menstrual cycle and didn't have proper sanitary wear to give her the comfort, dignity, and confidence to access the same institution she could use as a gateway to a better life. 1.2 billion is not just a number, it's the lives of adolescents whose biggest hope lie in what we choose to do today and the next day. The future is a 10-year-old adolescent today, but the future begins today. We have the best instruments locally, regionally. We've had many dialogues, partnerships. What we need now boils down to 4 main points. The first one is action. Second one, action. Third one, action. And the fourth one is action. Viva young people!
We need action, and there is one action more to do, which is that I met Gigi the first time a year ago when George Patton and I were at the Women Deliver meeting, and in chatting to Gigi at that time and asking her about some future plans, she said she wanted to stand to be a member of parliament in Botswana. And we asked her what did she need, and she said that she needed to raise $400 to do so. You have to stand, that's the fee. When I was having a Skype call with Gigi prior to this meeting, I was asking her, so how are the plans for government going? And she said, it's happening, but I need to raise the $400. So I did warn Anthony Costello that there was a charge here. Anthony last night at the opening ceremony announced that he was the self-appointed Goodwill Ambassador for WHO for adolescents. So Anthony, not necessarily personally, but on behalf of WHO and all of your contacts in the room, if you can't get some action to raise $400 to send Gigi to Parliament, you can do it on behalf of a whole lot of others. You don't have to do it from any of WHO, but as the WHO Goodwill Ambassador, you leave tomorrow night, and I'm expecting $400 to go to Gigi. Thank you very much. The final word is moving forward in terms of where is India going. We've heard a lot already about the RKSK initiative, and we will hear more over the next 3 days. I'd like to now finish this session by handing over to Jelani Manoj, my co-chair, to really take us into this position. Thank you very much.
Good morning to you all. Thanks, Susan. Indeed, very pleased to be here. Rather very excited also. I mean, if you look around the general air in the room, it's full of excitement, full of great possibilities, great opportunities. And just as I was hearing young Gigi, I mean, it's very difficult to pronounce your actual long name, but Gigi is a nice word in Hindi. I mean, although it's an elder sister, she's a young girl here, but in Hindi, it's Gigi is a elder sister. We normally reciprocate, but excellent, impassioned speech, exhorting us all to go beyond this room, the message to reach in the states, in the districts, in the villages, in the hamlets, going beyond this place to a place for action. So we need to really act to deliver for future of us all and for the future of our young adolescents and young children. Now, coming towards the end, when Suzanne said, we could, that's how we could structure, and it suited me well. Now, coming after 4 great speakers makes my job tough, and but then it also makes my job easier in the sense that much of the things have been said, and there may not be much to say something very new or dramatic. Now, so this is the broad structure of my presentation, but I'm grateful to Sunil for covering some of the things on situation of adolescent health, etc., etc. I'll share a bit more on the RKSK program, our main spearhead program for addressing the adolescent health issues. This is broadly the scenario. I don't need to be reiterating, excepting that look at where India is and where India would be. So when Suzanne mentioned and she laid the framework about the place, so it's 1/5 today, and it could even be more. So we really are at the right place. If we need to be addressing the needs of adolescents, it needs to start from the country which has the largest population of adolescents. And now the issues in terms of, the thing is that what you notice is in terms of time from MDGs to SDGs, and our own programmatic responses so far to adolescent health have largely been adolescent and reproductive health, at most to nutrition, but very importantly and very significantly with the advent of SDGs and all, and SDG 3, SDG 5, and within the SDG 3 indicators, if we look at it, in terms of injuries and self-harm, in terms of non-communicable disease, in terms of mental health, etc., etc., it is very, very important that they are center stage, and unless we address the issues relating to adolescents, we really are not going to succeed in our SDG targets. Now, this is reflection about the shifting pattern of disease burden. You look at the DALI's contribution on mental health and substance abuse. You also look at the contribution to the NCDs, nutritional deficiencies. Now, despite huge reduction in terms of early marriages and teenage pregnancies, it's still a very, very high number. This Sunil has touched upon, so I'm not going to touch on this much more, excepting that we really have a huge area, huge ground to cover. There has been some important progress, some encouraging progress, but a long road to go. Now, this is one is in terms of, as of now also the adolescent health is generally incurred in our RMNCA-H. So, it's the life cycle approach is talked about, but it's again seen in the dimension of reproductive, maternal, newborn, child health, while it has amongst the various life stages, this is one life stage which has implications on all the other programmatic areas within the overall gamut of activities of health, as I said, in terms of non-communicable diseases, in terms of areas of mental health, substance abuse, etc., etc. And as from the economics point of view, and Costello did bring out that it's easier and cost effective, so it's good economics to invest in adolescent health, and it yields much better outcomes when we invest in adolescent health, and it's critical for achieving is not only SDG 5 but various targets within the SDG 3. Well, what it contributes, it's the life cycle thing. I mean, not only now it benefits, it is healthy adults in the future and healthy future generations. So it's very, very critical that we invest in this. And this is some data in terms of Lancet article that investment of US dollar 5.2 per capita each year across will show remarkable benefits, almost 10 times the investment. So it's a huge cost-effective intervention, and countries need to increase their investments, and not only in terms of policy declarations, but in terms of actual practice by putting resources where our mouth is. Now, in terms of adolescent health, you are seeing as to how things have evolved, but we launched the important RKSK program. Now, this was in a way a major shift from one slightly curative-based approach, and as I said, only limited to reproductive health, to a much wider and holistic approach in terms of Rashtriya Kishore Swasthya Karyakram. So one, it looks at the continuum of care, so it's a life cycle approach, and then looks through multi-component and multi-level intervention in terms of programmatic priorities. So there is a sexual reproductive health, there is issue of nutrition, non-communicable diseases, substance misuse, injuries, violence, enhancing mental health, and these are the broad approaches in terms of 7 C's. So for 10 to 19 years, in terms of coverage, so both in school, out of school, married, unmarried, in terms of content of the program, so beyond reproductive and sexual health to a whole range of mental health issues, substance misuse, NCDs, nutrition. Working with the community. So for the first time, we moved on to domain of what Costello mentioned in terms of creating a community of young adolescents interacting amongst themselves, being mutual learning and all. So teachers to facilitate and health ambassadors, and then you have the peer educators both amongst boys and girls who are counseled, who are trained, and then they work within the peer groups. And then you have the clinics for adolescent and reproductive IRSH-friendly clinics, and then you have a 360-degree communication approach. Then there's a counseling, so you have an IRSH counselors across different facilities. And then a thing which is easy to say and difficult to implement is in terms of bringing about convergence between the areas of women and child development and school education department and youth affairs development department, public-private partnerships, non-governmental organization, etc. But unless it really genuinely becomes a partnership, we would not really be able to make progress in a way, in an accelerated way that we would want. So there is a facility-based approach in terms of adolescent-friendly clinics, then there's a school-based approach, and there is a community-based approach. So all the 3 dimensions at the level of community, schools, and clinics, there are interventions which are covered under the Rashtriya Kishore Swasthya Karyakram. There's a major program on weekly iron folic supplementation to create an anemia-free strategy during the entire life cycles approach. Now, in terms of what is there in the facility-based approach, so you have these adolescent-friendly health clinics at CHCs and district hospitals, and you have adolescent health counselors, the block level, who works as a block coordinator for all adolescent health activities. And also there's another program called Rashtriya Bal Swasthya Karyakram, which is a program for screening for all children between 0 to 18 years, and then taking them to a district early intervention center and then creating a medical response. Yeah, and then, so these are the school-based approach interventions. So you looked at facility-based approach interventions, then the school-based approach interventions in terms of various provision of services through the platform of schools, including for menstrual hygiene programs, and then there's also deworming, IFA supplementation, immunization program, and then very importantly, community-based approach, where you've got community peer education program through Sathiyas who are mentored by community health volunteers, community health workers called Aashas. And this really is to work with the vulnerable adolescent population group. And this has been taken up in about 231 districts and is proposed to be scaled up. Now, this is a different material to facilitate peer-to-peer interaction and to build up their capacities. So these are the progress in terms of physical progress, in terms of adolescent-friendly health clinics, WISP program, peer education program, and a menstrual hygiene program. You look at the numbers for India, everything is in millions. And now, these are some of the issues in terms of challenges. So one is in terms of disaggregated, inadequate data, but I'm sure with the advent of SDGs, there is a growing pressure in terms of creating disaggregated data with various on various lenses and various filters, so that you are able to make sure that no one is left behind. So in that sense, we would be capturing disaggregated data there. There is also an issue of perceived benefits. So when you make a case for adolescent health, it's easy to bring out cases for child health and all, child survival programs. It's easy to attract money. It makes life and death. But adolescent health, it's slightly at life skills kind of a thing, and behavioral change, and that is slightly difficult to convince to the to people who make financial decisions. It needs multi-sectoral actions, but that requires, it's slightly more complex and difficult and long gestation period to demonstrate impact. But let me again conclude where Gigi left, is in terms of a need to act and to need to create a better future for us all. Thank you so much.
Time, place, purpose, and partners. I think in this opening session that we've had today, we've had all of that. Please join with me in thanking all of our 4 speakers. Thank you.
Well, once again, we'd like to thank all our experts. Thank you so much for sharing your knowledge with us. And one more issue I feel that adolescents have, that is handling and managing their emotions. If somebody, would have taught me how to manage my emotions, I think I would have been in a better space. But there are many more issues that we need to address, ladies and gentlemen. I think unless and until we don't come together, we can't make our purpose fulfilled. And now, ladies and gentlemen, taking this further, our next session is on a Lancet Standing Commission on Adolescent Health and Well-being. Well, we'll be meeting the challenges of global adolescent health. And to do the honors for this session, our session chair is Ms. Vandana Gurnani. Ladies and gentlemen, she is Joint Secretary, Reproductive and Child Health Program, MOHFW, Government of India. Ma'am, I request you to please join me for this session on the dais. And with that, I would also request David Ross from World Health Organization, Switzerland, to please join me. Ladies and gentlemen, our session chairs are with us, and we request you to please take this further. Thank you.
So once again, a very good morning to all of you and a warm welcome to India. David Ross, my co-chair, Technical Officer, Adolescent Health and Wellbeing at WHO, distinguished speaker, Dr. George Patton, distinguished panelists for today, various speakers, colleagues, and all the spirited young people who are present here today. I'm acutely aware of the fact that probably the average age of people around this room would be less than 24. But the wisdom and the zest and the spirit that is here today is completely unmeasurable. And I'm extremely pleased to be here with you all for this plenary session on the most important landmark Lancet Commission report on adolescent health, and amongst all of you who I believe are the biggest champions who have relentlessly pushed the agenda and of keeping the adolescents at the center stage. As you all know, this Lancet Commission is the third after the first two in 2007 and 2012. And the first commission identified adolescent health as an emerging area of health and medicine. The second highlighted the importance of adolescent health to attain global health and the need for inclusive programs and policies. This commission came at a critical stage, as we all know, when we are transitioning from the MDGs to the SDGs, and also the demographic transition where the burden of disease has now shifted from the under 5-year-olds to the adolescents, as we heard about it yesterday. While at the turn of the millennium, the focus was on child deaths and ensuring survival, now the focus is on survive, thrive, and transform, and adolescent health are critical to it, as we all know. As far as the Commission is concerned, it has synthesized the literature on various determinants, whether it's social, structural, and biological determinants of adolescent health. It has undertaken a global analysis of health needs and conducted meta-reviews of the evidence for interventions, providing a new narrative for adolescent health, and it outlines investments that are required to improve the health of the world's 1.8 billion adolescents. And the report plays a critical part in making a very strong case for investing in adolescents. And as an economist by academic training, I would like to say whatever global or national noise that we may make about adolescent health and saying adolescents have to be at center stage, unless we have the resources flowing in for it, we really can't make a difference. So extremely important, the Commission report that would be presented today. I'm not going to steal the thunder from your presentation, George, but I really look forward myself, and I'm sure the group here looks forward to hearing you today. George Patton, I'd like to introduce him. He is one of the strongest champions for the Lancet Commission and for adolescent health. The 2016 Commission was led by him. He is a professor of adolescent health research at the University of Melbourne, Australia, a psychiatric epidemiologist by training. He has led many epidemiological studies on adolescent health and now is classified to belong to the species, as Dr. Paul was mentioning yesterday, adolescentologist. He has advised a number of us, including India, and was also present at the launch of our very comprehensive adolescent health program, the RKSK. And to work this commission, he has led international collaboration of the University of Melbourne, Columbia University, UCL, and the London School of Hygiene and Tropical Medicine, and has led a group of about 30 commissioners from 14 countries, including academics, policymakers, and young health advocates who span public health, neuroscience, adolescent medicine, social and political science, law, and education. So really look forward to your talk, particularly to hear about motor neuron cognitive development. We in India are very interested in that. I'd also take a moment to introduce our other panelists. We have a very distinguished panel here. Professor Marlene is the head of Department of OBGYN and Director, the Center of Excellence in Women and Child Health at the Aga Khan University in Nairobi. Ms. Kikelomo Taiwo is a sociologist and the member training coordinator at Amnesty International USA based in New York, and was a commissioner in the original Lancet Commission on Adolescent Health and Well-being. Dr. Sabina is a pediatrician and is a senior executive editor at the Lancet, who has overseen the 2 Lancet series on adolescent health and then the Lancet Commission on Adolescent Health and Well-being. So over to you, George.
Thank you very much, Vandana. Look, it's a great privilege and a pleasure to be talking to you today. As Susan Sawyer said, this is the largest meeting in adolescent health that there has ever been. And I, part of that success is undoubtedly that we're having the meeting here in India. Another part of that success is the work and the journey we've been on with the Lancet over the past little over a decade. That journey is one that many of you have been involved in over that time. It's a journey that began, as all good journeys do, it began over a dinner table conversation. So Sabina and her husband was meeting with a colleague of ours, Glenn Bowes and his wife, and they were talking about the new initiatives from the Lancet to have special series, initially starting with infant mortality, and the conversation turned to adolescent health. And the suggestion was made that, what about a series in adolescent health? That led to that first series. It appeared a decade ago on adolescent health in the Lancet. It was followed by a number of sentinel papers on adolescent health and led into a second series that, again, many of you here in the audience, the IAAH constituency, were involved in. That led into the Lancet Commission on Adolescent Health and Wellbeing that appeared in May 2016. And we're now continuing that journey with the Lancet. Now, it's a vote of confidence from the Lancet that they have asked us to establish a standing commission. There has never been a standing commission, a Lancet standing commission, in any field. So we should feel very privileged as a field that we have this vote of confidence from the Lancet, from Sabina, Richard Horton, and their colleagues. It's also a bit daunting because there's no map for a standing commission. So we're heading off into the unknown, and if you're heading off into the unknown, it's good to have a map in mind. And I want to illustrate the value of a map in terms of shaping our understanding of where we are in the world and where we might head. And I'd like to do that with this map here. So this is the Hereford Mappa Mundi from the year 1300. So this was a Western European view of the known world as it existed. So within that circle is the known world. What do you think was at the center of the world from that Western European view? Well, it was Jerusalem that was at the center of the world. England was out here. It was a long way from this place over here that one might want to journey to. So this was paradise out in the east. So the bad news, if you were growing up in England, it was a long way to paradise. But it was probably better than to be in Australia, New Zealand, the Americas, because we weren't on the map at that time. India was on the map. So this is the Indus and Ganges Delta. So you, at that time, were viewed as being very close to paradise, but not as close as Japan, which was the country closest to paradise. I put this up to illustrate the value and the power of a map in terms of understanding one's place in the world. And so it should come as no surprise to you, and those of you who've looked at the Lancet Commission report, and there are copies available at reception, will have known that maps figured prominently. The front cover of the Commission report had a map. And I'd like you to note where the center of the world is. Now, you have Susan Sawyer to blame for having India at the center of the world. And no, she wasn't thinking about this Congress being in Delhi at the time. Her rationale was the largest number of young people, adolescents, in the world are growing up in India. And so we must put India at the center of the adolescent health world. And she was right. So if you look through the Lancet Commission report, you'll see maps. And you've seen this map already, a map of where young people are growing up. So in terms of the present of adolescent health, that is in South and East Asia. A half of all the world's young people are growing up here. In terms of the future of adolescent health, it is in those countries with the reddish shades, largely sub-Saharan Africa, where the highest proportion in the population are young people aged 10 through to 24, where the proportion is over a third of the population. You've seen maps of this kind in the 2016 report. So the map of disease burden affecting young people around the world. And the message here is that young people growing up in different places have very different patterns of disease burden. So the purple colors represent young people who are growing up with multiple disease burdens during the adolescent years. So these are countries which are pre-epidemiological transition, affected by diseases of poverty, high rates of injury, and NCDs. The injury excess countries are shown in orange. So Latin America, high rates of homicide, high rates of unintentional injury, and the green, NCD predominant countries. This is an important message. So those NCDs are mental disorders, substance use disorders, a range of chronic physical illnesses. Those are the dominant problems in the green countries. So these maps are useful in beginning to shape our thinking about how we might act globally. You've seen this map as well, a map of accountability and what we actually need to drive systems. We need, as Tony Costello said, and Gigi, and many of the former speakers, we need good data. We need to communicate that data. We need to talk about that data, and we need to be able to act at that data. And you will see that young people are really important in terms of driving that circle of accountability. So, moving forward, we need better maps. So I'm going to address just in this presentation some questions that we're going to be asking about the Standing Commission as it moves forward. So there's 4 questions. Where are we now? What direction are we heading in? How do we get there? And what is our destination? Now, I don't know all the answers to this question because we're still in a planning phase, but we can begin to have a guess at what the answers might be. So where are we now? Well, as Susan flagged, we're in a very different time and place. And the world of adolescent health really changed back in September 2015, when the SDG era was ushered in at the UN General Assembly. At that same General Assembly, we had the introduction of the global strategy, not for women and younger children, but women, children's, and adolescents' health. First time this field had ever been on the global agenda. We couldn't have planned the timing and the publication of the Lancet Commission better because that appeared some little over 6 months later, in May 2016, at a time when the world was wanting a map, a narrative for adolescent health. How do we move forward with a comprehensive and integrated approach to adolescent health? Since that time, we've seen a huge amount of activity, much of it within the UN system. We've seen the establishment of a global financing facility at the World Bank. The H6 partners have become active. We've seen the PMNCH, the partnership, begin to restructure with one of its pillars, adolescent health. We've seen the launch of the global Iaah from WHO, sort of an initiative which is really about helping countries implement to scale programs in adolescent health. We're currently at this point here, shown by the blue line, and there's going to be more activity over the coming months. We're going to see the launch of the Countdown initiative. That's something which is unfamiliar to our field, but the Countdown is the measurement strategy, or part of the measurement strategy, for the global strategy, which now includes adolescents. So for the first time, they're going to be addressing adolescents in the report. We're going to see the launch of DCP3 with a whole volume on 5 to 19-year-olds. And the summary paper will appear in the Lancet later this year. And we're going to see the launch of the Standing Commission early next year. So this is an incredibly exciting point for our field to be at. What direction are we going to head in? And these axes represent some of the fundamental axes of the previous commission that we're going to carry forward into the Standing Commission. So data and evidence are going to be where I'm going to focus. Marlene is going to talk about capacity building. And Kiki Lomo is going to say something about youth engagement and partnerships. So data and evidence. An idea that we pioneered in the 2016 report was one of minimally sufficient data to drive programming. And if you're thinking about any area, minimally sufficient data is going to be about how common is the problem, what is the coverage of essential interventions, and what are the risk factors that we might target with prevention? So I just want to illustrate the challenge ahead in an area of mental disorders. And this is based on a publication from earlier this year from Holly Erskine and her colleagues, looking at the global coverage of minimally sufficient prevalence data. That's the starting point of mental disorders in children and adolescents globally. How much do we know? What is our global coverage? Well, the answer globally is 6% in terms of the major mental disorders that affect children and adolescents. So these are children over the age of 5 through to 19. The coverage in low and middle income countries is 4.5%. 124 countries have no usable data at all in terms of estimating prevalence of any mental disorder. That is the challenge that we face moving forward. We're starting from a low base. We've also been looking at this question of minimally sufficient evidence. And some of you might have seen this mud map. It didn't appear in the report, but I've talked about it, to say where we can, on the basis of the meta-reviews that appeared in the 2016 report, where we can confidently say we have good evidence, we have that evidence from low and middle income countries as well as high income countries. And those are the dark green colors here. So, you'll see here, sorry, I thought I had an animation, but it's sexual and reproductive health, which has been the major focus where the best data exist. So Nicola Reevely, who worked with us on the 2016 report, has done some further work, which I'd like to show you by illustrating how far we have to go in terms of getting minimally sufficient evidence on sexual and reproductive health, which is the area that looks best. So Nikki took the 3IE report. It was called a gap map that appeared sort of earlier this year on sexual and reproductive health, extended it using the studies in the meta-reviews to high-income countries as well as low and middle-income countries, and defined minimally sufficient studies as those which used an experimental design of some kind, not necessarily an RCT, it could be a quasi-experimental design, and looked at least a behavioral outcome or a health outcome. So, what does the world look like in terms of sexual and reproductive health needs of adolescents? This is the burden of disease mapped here, with the dark, deep red colors representing the highest burden of disease due to sexual and reproductive health problems. So those include HIV, maternal health problems, and sexually transmitted infections. Okay, where do we have the evidence, do you think, in terms of sexual and reproductive health across all countries? There are 192 studies that meet that minimally sufficient evidence point, and this is where they are. 118 of them are from the United States. Nigeria is the next best in terms of 7 studies. We have a mismatch between the evidence base and where we need that evidence in terms of programming. That is, where adolescents are growing up. That's a challenge for us. Illustrating that in a different way, across World Bank regions here. And I don't know if I can do this, but it's our first region, with the region in green is North America. Again, the biggest data. We have quite a bit of data from sub-Saharan Africa, given the focus particularly on HIV in adolescents. But if we look at that minimally sufficient level, in the meta-reviews, so these are the reviews that exist that drive policy, we have only 2 studies from South Asia, and we have none from the Middle East. So we have a challenge ahead. Just illustrating that point in a different way, looking at adolescent birth rates and asking the question, can FP 2020, a really big initiative in terms of family planning, which is stuck at the moment because of continuing high adolescent birth rates in many parts of the world. So asking the question, which World Bank grouping in terms of higher, upper middle, lower income countries, where are the adolescent birth rates highest? Where is the SRH daily rate highest? Well, it's in lower and lower middle income countries. So where is the evidence base again? Well, it's almost the mirror image, opposite direction. So this, for us, is a big challenge. Just looking at that in one last way, which is asking the question, are we getting better? So looking at studies and the profile of studies before 2000 and those after 2000. Because you might say, well, with the MDGs, we're getting better. We're getting a little bit better, but not nearly to scale in terms of the evidence base for action. So that's going to be a focus for us. So in terms of those directions, we have some themes which we drew from the 2016 report that you've already heard a bit about today. So Tony talked about quite a few of these. Universal health coverage. Adolescents are the least well-served age group across all age groups in terms of the operation of health service systems. The health education interface at a time when the world is expanding secondary education. This is one of the best opportunities we have for adolescent health. And you will have seen the work around legal frameworks that Terry McGovern from Columbia led. Brilliant work on the different legal frameworks, perplexingly different in different countries. So Terry and her group are going to be continuing that work forward into the Standing Commission. And in all of this, we're going to be looking at adolescent health from a developmental lens, recognizing this is a unique phase in life, in growth and development. What works for younger children won't necessarily work in adolescents. What works in adults won't necessarily work for adolescents. Okay, how do we get there? Well, this is the map of who was involved geographically in terms of the first Lancet Commission. So the green colours, we had aspired to have geographic diversity and disciplinary diversity. So we did have teachers, lawyers, we had neuroscientists, political scientists, economists. Those were all the disciplines, in addition to the traditional disciplines of clinical medicine and public health, as part of the first commission. We need to continue with that diversity. We were effectively trying to create an academic community for adolescent health. Some of those institutions really had broad networks. So the London School for Hygiene and Tropical Medicine is an institution with networks that span out right across the globe. So in a sense, what we were creating with the Lancet Commission was a network, a community, a network, and that's what we need to expand in the next phase. How do we get there? Well, we needed to do this in partnership. So partnerships with the UN agencies. This has to be a working with. A partnership with the international NGOs, a partnership with the donor community, and most importantly, a partnership with young people. And I just want to flag that we have 6 new members of the Youth Network, in addition to Kikalomo and Dakshita, who were our youth commissioners in the first commission. They are going to be essential partners for us in the work, in developing a communication strategy, and in connecting with young people around the world around the Standing Commission's work. Okay, so what's the destination? I don't know the answer to this question yet, but I've got some ideas. Part of the ideas, and something that was really picked up in the first Lancet Commission report, were these profiles of adolescent health. And the profiles were more complex than this. They looked at burden of disease and change over time. They looked at mortality, they looked at risk factors and how these were changing over time, looked at the social determinants of health and some of the platforms for service delivery. This is beginning to be the kind of information that we need as we are planning our policies and programs for adolescent health. So we need to extend that work, but we need to extend it to a subnational level in places like India, because it's the states in India that drive many of the systems that are so important for health. We need to do more work. Vandana, this slide is for you, on the economics of adolescent health. Some of you will have seen the investment case that appeared in the Lancet earlier this year, in May, I think it was, this year? I think it was May, which actually looked at this notion of the benefit-cost ratio. Benefit-cost ratio is an indicator, $1 in. For a benefit-cost ratio of 1, you get $1 back. A benefit-cost ratio of 2 means you get $2 back in terms of every dollar you put in. A benefit-cost ratio of 2 is generally seen as a really good investment if you're building roads or power stations, infrastructure. And I flagged that there at this line. So Peter Sheehan and his colleagues looked at 5 interventions: HPV vaccination, prevention of road traffic injury, prevention of child marriage, promoting secondary education, and adolescent health care. sexual and reproductive health care, but extending to mental health counselling, and looked at the benefit-cost ratios in low, lower middle, and upper middle income countries. And you see that these are outstanding benefit-cost ratios. They range from 8 up to 25. That is incredible value. It's of a similar order of magnitude to the best investments we make in the health of younger children, women's health. Adolescent health is a good investment, and that's without considering the intergenerational benefits, given that this is the next generation to parent. So, just in terms of where we're heading to, it's this kind of information that we need to be pulling together in this next phase of work for the Standing Commission. It's those elements that will create a national investment case or a subnational investment case. It's creating effectively a mappa mundi for adolescent health for the future. I'm going to leave it there. Thank you very much.
Thank you so much, George, for this brilliant presentation. I'm sure the audience here is bubbling with questions, but we have a historical lag of 15 minutes from the previous session, so probably we can take 2 questions, and I request the delegates to limit their exposition to the questions, specific questions, without any preamble. I see your hand there, yeah. George, would you like to lead? The questions are for you.
Okay, apologies. Yes. Have we got a microphone? Yeah.
Hi, my name's Kajal. I'm one of the doctors working as a paediatrician and training in adolescent medicine in Western Australia. I've just got one question. I think it's amazing that you're actually looking at getting an evidence base in the countries where it's needed, so the information you're getting is applicable. But I think there is one population that we're actually missing at the moment. There are millions of undisplaced young people around the world in the form of refugees, people who are stateless, asylum seekers, and at this stage we don't even have numbers. So the UNHCR collects data from 0 to 18 and 18 and above, and this is a highly vulnerable population. So when you actually look at where a person originates from and countries they come from, you can place that on a map and map it. But for this population, we don't even have that. And I was just wondering if through the Lancet Commission there was any consideration of looking at this population as well.
Look, you're absolutely right. That is a huge problem that the world faces. So conflict, forced migration, rapidly changing patterns of health risk, particularly and problems for this younger age group. Yes, it is a population that we think is very important. So that theme of equitable systems, there are a number of ways in which inequity is structured into adolescent health. We're talking quite a lot as a global community about gender inequities, and they're very, very important, socioeconomic inequities, but this is a new problem that we are certainly facing. And in terms of data, yeah, we don't have good data. It's difficult to get good data from those places where there are high numbers of young people, and it is young people who are more affected, really, than any other age group. Hard to get data. The studies are not yet being done, or they're being done, but we don't necessarily have the evidence from them. The donor community is investing sort of in this group, recognizing that we run the risk of heading backwards if we don't invest in this group. So yes, we will be considering that group. Thank you very much for your question.
Thank you.
This is Rajiv Seth from Delhi. The challenge of internally displaced people have never been addressed by the international community.
Yeah.
There is a whole intent of attending to refugees. Well, I agree. 60 million children are amongst the displaced. 15 million will be refugees and about 45 million will be internally displaced. In India alone, we don't have data about our street children.
Yeah.
You know, about 18 million and 20 million. Even in the city of Delhi, as we sit, about 50 children go. So there's a huge numbers that we are talking here. And I think these needs to be addressed. There's no UN statement on these internally displaced children at all.
Yeah, look, again, I agree, and the reasons are sometimes they're conflict, sometimes it's economic factors that are actually driving it. China is a good example where sort of if you migrate internally as a young person, you lose access to services such as health and education. So this is a big problem, and I agree that the international community has not addressed it. In terms of the architecture of data collection, it's really about sort of people who are in school, young people in school, or young people who are in households. So the data collection system's not addressing it. We're not addressing it, giving it priority in terms of the evidence base. And that exercise that Nikki has done has actually looked at some of these subgroups who are particularly disadvantaged in terms of data in the evidence base. And the studies in these groups, they're minimal in terms of number. So thank you again. You're absolutely highlighting a group who we should be focusing a lot more attention on, and we will try to do so. Thank you.
Thanks, David. I think we have to stop with the questions. I hand over to my co-chair, David Ross, to invite the panelists to speak to all of us.
Thank you very much. I'm just going to ask a few questions to the panelists. So starting with Professor Marlene Temmerman. So Marlene, the Lancet Commission identifies training and supportive mentorship of health staff and workers in other sectors as a top priority moving forward in adolescent health. What's the current situation and what is needed in that?
Thank you and good morning to all of you. Very happy to be here at the largest adolescent health conference and very happy to be in the Lancet Standing Committee to focus and support the capacity building of a generation of young leaders in research, in healthcare provision. And how are we going to do that? I think we need to create in the low and middle income countries, but in collaboration with Western institutions, we need to create this new generation of leaders. Looking back at my own career, how were we trained? We were trained in doing good research. We were trained on the holy grail of publication, publish or perish. We did a lot. We have a lot of evidence. Anthony talked this morning about evidence-based implementation. George mentioned data and evidence, and it's true. We need it. But we have a lot of data, we need more. We have a lot of evidence, we need more. But how come that all this is not changing the world fast enough? We have contributed. Look at the HIV world. But what we need is to create a generation of leaders who do more than research, more than practice and publication, but who know how to deal with politics, media, communication. I've been, Gigi is not here, I run for election in my own country. I was elected from an academic and politician to a senator. I worked many years in my own parliament. I worked in the Interparliamentarian Union. And I realized that all this great evidence we publish, and we are surprised that the world doesn't take our great data. Because we don't communicate, we don't have the same language. I give you one example, because of time constraints. When I was at the Interparliamentarian Union, I was one of the key people working on HIV/AIDS with parliamentarians. Now, a parliamentarian doesn't read the Lancet. Parliamentarian is not re-elected when you talk about sex, about condoms. Maternal health maybe, but all the sexual issues difficult. So we decided to write a handbook with the scientists for parliamentarians. We did great work, 120 pages, translated in all languages. I'm sure that not one parliamentarian read the handbook, because we were from a science world talking to them and not understanding their languages, their needs. We learned a lot. Same with media, communication, communities. You don't go, I live in Kenya, you don't go to a rural area to talk to the chiefs with your evidence. Yes, you need the evidence, but you need to translate. So, what I think what we need to create is a generation who is doing good research, who can publish, but also who develops skills in communication with the other, with the media, with politics. And, you know, that's what we need to make them more vocal and to have more impact. And I think that is one of the challenges.
Back when dinosaurs, yes, thank you. When dinosaurs were walking the world and I was trained as a medical doctor, we didn't even hear about adolescence. I don't remember the word in all those years. What needs to happen now, in terms of not just training doctors, but also nurses and all the other staff involved?
Just one thing to add. I'm an obstetrician gynecologist, and I worked in many parts of the world, in Europe, in Africa. I did about 18,000 deliveries in the many years, but I also had 72 maternal mortalities, which is quite high. And many of them, most of them, were the young girls who had their abortions done in the back street of Maputo, in Nairobi, in South Africa. And then they came to the hospital. Usually they did it on a Friday night. They came to the hospital if they survived. On Sundays, the wards were plenty with these complications of these unsafe abortions. So what did we do? What do we need to do as healthcare providers? We just cure and we go on. I think we have to strengthen that community of healthcare providers to raise their voices. You know, it is not, if your maternal mortality rate remains high, and in most of the settings in Kenya, we are still at a very high rate. So we work with nurses, obstetricians, doctors, pediatricians, and we see that despite all our efforts, the rates remain high. Somebody is accountable. If there are no supplies, we have to raise our voices. So we have to train and to empower and to organize the healthcare workers that they can be a very strong voice in accountability. If women keep on dying because of postpartum hemorrhage, we can give the statistics, we need the data, but what's missing is the accountability piece. Who is a district, a community talking to? And now, most of the healthcare sector, they have been devolved, so there should be, the ones who have responsibility should be closer to the healthcare providers. So we have to train researchers and healthcare workers to be able to reach the other communities.
Thank you very much, Professor Temmerman. So, Ms. Taiwo, Kiki, you were one of the commissioners on the original Lancet Commission on Adolescent Health.
Absolutely.
I'd like you to just tell us a bit about your experience of that, and thinking forward, how should the future commission, standing commission, and other similar initiatives involve younger professionals like yourself?
Absolutely. Thank you very much. Good morning, everyone. It gives me so much pleasure to be here with everyone at the International Association of Adolescent Health, World Congress on Adolescent Health. My experience in the Lancet Commission was a very positive one. In fact, when I got the news that I was selected, I was completely, blown away and, really thrilled that I will get the opportunity to work with the best of the best in the field of adolescent health. And it's been quite an experience. I know one of the challenging things I faced in the commission was just understanding research. I wasn't necessarily from a research background. I'm a youth advocate at heart, core community youth advocate, working in Nigeria to engage young people around meaningfully engaging in policy-making processes and also engaging policymakers to create that space for young people to engage in policy-making processes. So coming into the Lancet Commission, I had a hard time, just really understanding, the terminologies, the research language, and all of this data and all of that. I am all about how that translates into healthcare services, what that means, for young people in the community. And I remember, one of the recommendations that we put forward in the last commission was that, in order for us to be able to do this work effectively, yes, there is need to engage young people meaningfully, but what does that even really look like? The fact that I'm in a room doesn't necessarily mean I'm engaging meaningfully. And I think, this kind of piggybacks to, what you said about building capacity and preparing young people to engage. Young people cannot engage meaningfully if they don't even understand, if they cannot comprehend why they're there in the first place. The other point I want to make is about, the other recommendation that we made was to increase participation. One of the things that I wondered about was the fact that Dakshita and I, even though this was a great step for the Lancet Commission to even think that it would be relevant to have 2 young people in the commission, but we knew that our perspective, our views by no means, is in totality in totality reflect the worldview of young people around the world. And one of the things that we grappled with was how we can make our representation more impactful. How can both of us really capture the perspective of young people around the world? And one of the recommendations that we put forward was there has to be more young people in this commission. Like, if we really want to have meaningful representation, then we need more young people. And I'm really glad that they listened to us. Now we have 6 more, young people. And I mean, that's good. That's good. Talk about action. Talk about action. Talk about integrity. Talk about leadership that listens. And to add to that, one of the things we're looking forward to do moving forward with the Lancet Standing Commission is to ensure that, yes, we have 6 people in the commission representing youth voices, but how can these 6 really maximize their role and engage even the broader global youth? And so going back to the issue around partnership, we're looking forward to working with existing systems and structures like the Women Deliver platform is an amazing, amazing program that really builds capacity of young people in the grassroots around the world. We're looking to explore those existing platforms. There are other institutions around the world that are doing amazing work, and we want to make sure that we're really keen into what already exists. I think the big challenge that we will have moving forward is interpreting research, communicating research to youth advocates around the world in a way that they understand and that they can connect with. I'm looking forward to the work that we will do in the coming years.
Ms. Tara, Kike, thank you very much. Yeah, I still remember the look on my son's face when I was sitting there in the sitting room chatting with a statistician colleague, and we were talking about p-values. And P in English means urine, and he didn't quite get it. Right. So I know that the issue of needing to get so that we can talk to each other and the importance of mentorship, and I'm really glad that you and Dakshita will continue to mentor the new people coming on, and also keep the oldies in check when they start talking about p-values. So, Dr. Kleinert and Sabina, you are the senior editor responsible for the Lancet series, the 2 Lancet series, then the Lancet Commission, now the Standing Commission. What do you want from it?
Okay, thanks. That's a very tough question. Because as George explained, this is the first ever standing commission that we're doing at the Lancet. So let me just briefly explain where we got to, with adolescent health and the Lancet, and why we decided to do a standing commission and what I think this might look like. But, this could still change with all your input, with the commissioner's input, with the young people's input. So, the series were really there to just say, oh, there is such a thing as adolescent health. The second series was sort of explaining we need to think about adolescence in the global health context much more than we do. It's not just a discipline in its own, little bubble. We need to go out there and make it matter for all global health agendas. And then the commission, and Anthony Costello has talked about wicked problems this morning. And in commissions, what we try to do is take wicked problems and work on them to come up with a very substantive report that then serves as science-based advocacy. And I think that's what we have somewhat achieved with that Lancet Commission and really the leadership of George and Susan and all the other commissioners, including our youth participants, with the 2016 commission that was published in May. In my mind, that commission answered the question, why should we care? And on a very high level, it also perhaps answered, what should we do? So there were recommendations, but they were very, very high level. So for a standing commission, and George has highlighted the directions such as, yes, we need more data, we definitely need to go into capacity building, we definitely need to talk about meaningful youth participation with young people, not just for young people or young people as a token. And we need to talk about implementation science, but I want to push this standing commission even further. I want to go to this word that Shishi has mentioned in her conclusion, the 4 points, action, 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 and action. So for me, the standing commission, the report that I'm expecting in maybe 3 years' time, should really go far down the route in answering how should we do things. And we should go down to country level, to subnational levels, and give much more guidance on the how, by examining the barriers, by trying to give advice on how these barriers can be overcome. And this is what I'm hoping to see when we have the next World Conference, and this is what I'm hoping to report on then. Thank you.
Great. Well, that's quite a challenge, so I think you better get it done before tea. And then we'll move on to a relaxing time in India for the rest of our time here. But commissioners, many of you are in the room, and congratulations for the commission, for the original commission report, and now the task is there and the challenge is there. So, would any of the commissioners who are in the room, either from the Lancet Commission or from the original or standing, to stand? So that, yeah, so congratulations everybody. We are going to finish at 10 past. We started at 15, so we've caught up, we'll catch up 5 minutes. So we've got 5 minutes, please do sit. We've got 5 minutes in case anybody has any further questions or comments that they'd like to make. You're going to have to be quick, so jump up, run to the front, and grab a microphone. Anybody want this one? Yes, there's a hand over there.
Good morning. I'm Sonvi from Dasra, and we're very interested in the whole adolescence issue. I had a question around the very epidemiology of data collection, right? In a very fast-moving world, the relevance of data is very high. At the same time, how do you keep up with it? And I was wondering if Lancet is one of, and this is to you, Professor Patton, if you are thinking about evolving the space of data collection per se, to take it beyond the jurisdiction of the few experts in data collection to the community, so that the community can hold the data, own the data, collect the data, and it's still quality enough to be aggregated at a subnational and national level and be considered very relevant and useful for planning. Because it's almost every field, whether it's health or it's law, is having to hone the community skills to really go down to that level, to reach that kind of scale. So I was wondering if the data space is also thinking about honing community skills on that.
Thank you so much for that question. And we probably need sort of a couple of hours to actually answer it in terms of sort of how we might do it better. So you're absolutely right. The data is not granular enough in terms of what we have. We need to be able to take it down to that subnational level. Take India, for example, the problems of adolescent health. are completely different in the north to what they are in the south. So one needs to get down to that level of detail, and even within a state is, where you might have 100 million people. Again, it's going to be different in different districts within the state. So we need data at that level of granularity. We need greater breadth and integration of data collection systems. One of the problems that we have is we've tended to focus on certain aspects of adolescent health. So in the MDG era, we had a focus on reproductive health of young women, and we had a focus on HIV in some parts of the world, but most of the rest of adolescent health, most of the major problems were not really the focus of data collection systems. So we've got a patchwork quilt at the moment of data collection systems, if you want to call them systems, that give us an incomplete picture of adolescent health, one that isn't necessarily integrated, even within an area such as sexual and reproductive health or mental health. It's one that gives us an incomplete picture in terms of ages, and younger adolescents are largely missing from these global data collection systems. We have the Global School Health Survey, which is a really important data collection from WHO, but it only captures kids who are in school on the day of the survey. And there are sort of lots of kids who are not in school or not in school on the day of the survey. So we need to extend those systems. We need to integrate across not only health problems and health risks that affect adolescents, but the determinants. So one thing that we could be doing better is integrating data collections across health and education. At the moment, these two systems don't work together. And until we actually get a data collection system on what the needs are in terms of education and health that is joined up, we won't get those systems working effectively together. And that is essential for anything that we do in adolescent health. So one of the questions is, digital media. That is a new opportunity that we have. Industry uses totally different data sources to those that we use in terms of health policy and planning. So that's a new opportunity. We don't have a lot of expertise in that generally within public health. So we need to go out and talk to the people who know about these things. And yes, that's something that we're wanting to do.
Okay, we have one more question. You've got to be quick. Great. Yeah, over here. Oh, right-sided bias. Or is it left-sided, where you're facing left-sided bias? Go for it.
Good morning. My name is Karine. I'm a gynecologist from Brazil. And you told us that most part of the publications are from US. And we need to change that. But I was wondering, how do you plan to make it? Because most part of the countries that need to do publications, we don't have so much money to do so high quality research or publications that meet the strict criteria of the big, how can I say, the publication, to meet the publication criteria.
Thanks for that question, and I think that is one of the streams in the Lancet Standing Committee that we really want to address. There are far too many publications that are biased towards the West. On the other hand, there is increasing capacity, more literacy. I'm impressed by where I work to see how many people have gone through education, so they have the potential to publish, and we need to do research, and to be the first authors. So what we need is really hubs in the countries where we work together, but where the West, in brackets, supports people locally, because they are the ones who have to come with the ideas. They are capable, with support maybe and capacity building and mentorship, to develop good research proposals and to take the lead, not only to be number 17 on a publication, but to be the first author and the senior. And I think that's what we are trying now to build up in this capacity. It should be unacceptable that publications are only by Western countries and not led and not owned by people in their own communities.
And I just want to add, as part of the Standing Commission, and I should have said that, is also that we expect, pieces of research work to come along the way, and as Marlene has described, within sort of partnership, but very much led from people, from low and middle income countries, and would be very much open for these to be published in one of our Lancet journals. We now have also the Lancet Child and Adolescent Health Journal, which has just opened earlier this year. So there's a lot of opportunity for that from our perspective as well.
One sentence. Great question. Bringing visibility to the need is a starting point. We are at a point that women's health was at back in 1975 in terms of our technical base. We need to be working from now with those who are able to influence the collection of data, the better evaluation. So those include the people who are technical within countries, but it's also the donor community. I think the UN agencies have a really important role here. So that's where we're starting. But we're not going to get there in 3 years. We need to see this as probably a journey over the next 30 years.
We're now going to close, but I just want to tell you what's coming next. And first of all, to thank very much the panelists for an excellent session. And to thank my co-chair, Vandana Ganani, for getting us off to a great start. Even if it went downhill with the chairing after that. So you may not realize it, but you are in the Peacock Ballroom at 11:30. There will be 3 different parallel sessions happening in this room in different parts of it. So you'll need to find out which one is Peacock Ballroom 1, 2, or 3. And then downstairs in co-meeting rooms 1, 2, 3, and 9, there will be other parallel sessions. It's on the program. We can all read. Let's try and find it. So downstairs if you're going to co-meeting, here if you're going to be in the ballroom. Do you want to say anything? Or cool. So I think we're ready to rock. Tea and coffee is outside, and other, no doubt, wonderful snacks.
All right, thank you so much. Once again, we'd like to thank all our speakers. Ladies and gentlemen, all those who have not submitted their presentations, we request you to please submit it at co-meeting room 8. So I request you, speakers who haven't submitted their presentations yet, please do that. We need your presentations in the afternoon. And with that, ladies and gentlemen, we'll be breaking for tea, and we request all of you to please be here at 2:30 as we have our plenary symposium and debate. Thank you so much.
Down. Lights बहुत तंग कर रहे हैं ना. So all the speakers are here, speakers for this session. We were expecting 6 people. 2, 3, okay. Okay. We have all of them, and if the gates can be closed now so that we can start. Okay, so Sharmila will announce this session.
Good morning, everybody. and welcome to this session. I am Sharmila Niyogi from USAID, and with me is Dr. Rajesh Mehta from WHO CRO. And this session is about health system strengthening. I just want to say one thing before that session. Whatever we are talking about regarding adolescents increasing their access to universal services and with equity, with quality, none of these things are possible without addressing health systems. So that is one of the major pillars that we need to work on. And I'm happy to say that we have from different countries an array of presentations which are talking about some of the good practices, some of the challenges, and some of the studies that have been conducted regarding health systems interventions that were addressed in these countries. So I would, without much delay, because we have limited time, and here I would also like to announce that the speakers need to restrict themselves to 8 minutes. And after each speaker's presentation, we'll have a discussion time for 3 minutes, and we'll see in the end if we have some more time for more questions, we'll take them then. So I would like to invite our first speaker, who is Dr. Moira Berry, and she's from WITS Reproductive Health Institute. She's going to talk about implementing adolescent youth-friendly services in 2 health sub-districts of South Africa. Moira, over to you.
Thank you. Hi, good day, everybody. My name is Moira Berry, and I'm with the WITS Reproductive Health and HIV Institute in South Africa. And today I'm presenting work from the Adolescent Innovations Project, what we've been doing to strengthen adolescent and youth-friendly services in South Africa. So first, let's begin with a story, and I'll introduce you to Bongi. Bongi represents many of the young people who we work with. Bongi is 16 years old, and she lives in Johannesburg with her grandmother. Bongi was born HIV infected, and every month she goes to the clinic to collect her medication. Sometimes she stays late after school to study or to socialize with her friends. And if she arrives late at the clinic just before closing time, the nurses shout at her for coming so late. Bongi wants to spend the afternoons with her friends. She doesn't want to go to the clinic. She's bored of taking her tablets, and she's tired of being treated badly at the clinic. She's tired of the long queues, and she thinks, I feel healthy. I don't want to be here. What's the harm in taking a break from my medication? Does anyone at this clinic even care? Bongi is one of about 15 million adolescents and young people in South Africa. They make up about 26% of the population. And she's one of 450,000 young people aged 15 to 24 who's living with HIV. In South Africa, adolescents remain at very high risk of HIV. Incidence of the disease is very high in this age group. There's also high rates of STIs and teenage pregnancy among this group of people. In South Africa, primary health care services are free, and this includes HIV testing and care, contraceptives, antenatal care, TB treatment and care. And the age of consent for medical care is 12 years. So anyone from Bongi's age can be in charge of their own care without needing parental consent. But despite all of this, there are still many barriers to young people accessing care. This includes bad staff attitudes, stigma, particularly related to HIV, concerns around privacy and confidentiality, clinic operating hours that conflict with school and with work, and high transport costs to get to a clinic. One of the ways to address some of these barriers to care is to make health facilities more friendly towards young people like Bongi. The Adolescent Innovations Project has been working in 31 clinics over the past 5 years to strengthen adolescent and youth-friendly health services and to meet the following objectives. So the first is to reduce barriers and increase access to health care for young people. Also to improve knowledge levels on sexual and reproductive health. This includes HIV, STIs, and contraception. And also to capacitate healthcare workers to manage adolescent and youth concerns, to respond well to adolescents, including with just a friendly attitude. And also to assist healthcare facilities with AYFS, or Adolescent Youth Friendly Services recognition and validation, which is based on a set of national standards. So the foundation of the AYFS methodology in South Africa is the assessment of the youth friendliness of clinics. And assessments are conducted using a tool which can evaluate clinics' performance towards 10 national AYFS standards, which are listed here on the screen. And these standards relate to the management of the clinic, the friendliness of the environment for young people, and clinical service provision. So this tool, as well as the 10 standards, make it possible to compare clinics nationwide towards their AYFS progress, and it can be used in contexts outside of South Africa to ensure youth-friendly service provision. Also in South Africa, the National Department of Health has an adolescent health policy which creates a supportive policy environment for adolescent health and puts it on the national agenda. So the assessment tool highlights areas where clinics are performing well or are performing poorly in terms of adolescent service provision. And they can be repeated, the assessments can be repeated over time to measure change. And then the Adolescent Innovations Project has additional layers of support that we provide to the clinics that we work with. So, after an assessment is conducted and you can see where the gaps are, a critical step is to get buy-in from facility staff and to identify a single individual who can be an AYFS champion inside a facility. And the importance of having one person to move this kind of work forward inside a facility can't be overstated. We've taken on a long-term process of providing staff capacity building through training and mentoring, and this is really a multi-year labor of love. This can't be achieved in kind of a one-week training or a one-week workshop. This is an ongoing process of continuing to work with facilities. When a facility is ready to self-identify as an adolescent and youth-friendly facility, we recommend that they have a launch day with community partners where they can sort of come out in the community as an adolescent and youth-friendly space, an adolescent and youth-friendly clinic. And then over time, implement a series of quality improvement projects and innovations in adolescent care. So this may include a fast queue so adolescents can get in and out of a facility quickly, or extended operating hours so adolescents are able to visit a clinic after school or after work. Some of the tools that the Adolescent Innovations Project has developed to support AYFS implementation are the following. We've developed a guidebook on working with adolescents living with HIV. For those of you working with HIV populations, this can be downloaded from the WITS-RHI website. And this is a toolkit which can be used for training, but also for implementation of good, high-quality HIV care and treatment. And this is used primarily by clinicians. We've also developed in partnership with the National Department of Health, bewisehealth.com. And this is an adolescent youth-friendly Mobi site meant to be viewed on a cell phone. And this has access to relevant and accurate health information for adolescents and youth, and again is relevant outside of the context of South Africa, covers a wide range of health topics far beyond HIV. And in addition, we have innovations in adolescent care. So these include youth care clubs, which might be described as a sympathy group. It's group management of psychosocial support and also HIV care for a group of adolescents who meet on a monthly basis to access their HIV care together in a group environment. And also health connectors who are peer navigators who help young people link from HIV testing onto care and treatment and provide a very personal support that we know a lot of young people need. In terms of the results of some of our work, this is an aggregate of AYFS assessments, over 3 assessments at our clinics between June of 2015 and February of 2017. The scores have been averaged across all facilities per standard, so this represents assessments done at 30 clinics. So overall, the trend is that AYFS scores have improved. In one of our subdistricts, the scores improved by about 26%. And these changes, it must be noted, represent more than 600 hours of in-service training and mentoring in clinics. We visit most of our clinics on a weekly basis. So in conclusion, successful implementation of AYFS is really the foundation for improving access and quality of adolescent health services. This is relevant to HIV, but also to a broad range of adolescent health needs. Buy-in at all levels, from national down to the ground level, facility level, is extremely important. We're lucky in South Africa to have a supportive national policy environment, but a lot of the work really remains to be done on the ground with facility-based staff who are the point of contact for our young people in health systems. And then finally, an evaluation is underway, and we're looking at the relationship between AYFS scores at clinics and adolescents' clinical outcomes to see, is it worth it from a clinical perspective to be investing in the adolescent youth friendliness of our healthcare facilities? Thank you very much.
Thank you. Thank you. That was a great, presentation about, how some of the elements have been used to strengthen the system for the adolescents and make it more responsive for the adolescents. We now have time for 3 questions. So if anybody would like to ask questions, please raise your hands.
So quick interventions so that we keep to time. So, do we have a mic here? Anyone has a mic?
My name is Sophie Makoroma, and I come from Malawi, so I can identify with the presentation. Thank you. I wanted to follow up with one question. I noted that one of the barriers you talked about was staff attitude, and I also noted that through your intervention, there's been an increase in capacity. So I just wanted to learn, how has the increase in capacity translated into the change of staff attitude in the healthcare units?
Sorry, the question was about staff attitudes. I heard that correctly? Yeah.
Can we take 2 more questions?
Sure.
And then anybody else wants to ask? I think we have a hand there.
Yeah. Hi. I'm Dr. Nitin Bajpayee from PFI, Population Foundation of India. My question was on the slide where you showed the standards, standard 1 to 10, and then you said that was 26% increase in the overall thing. Can you also specify which intervention actually led to this 26% maximally?
I just have a question about whether any of the clinic-based programs then translate into hospital-based programs and other sort of non-AYA clinics. So is it a disconnect after they have this fabulous experience in the clinic, then they go and get admitted to the adult ward, or they go to a mental health clinic, for example, and then it's totally a different kind of experience? If you could just talk more about that.
Okay. Thanks so much for the question. So the first question around staff attitudes and capacity. We've hosted a number of focus group discussions with young people, and we found that their overwhelming number one sort of criticism of healthcare clinic is around staff attitudes. And people are happy, especially young HIV positive people, they're happy to keep coming to a clinic to receive their medication, but they just want to be treated well. So it's been a very big focus of the mentoring work that we've done, is really just working on those attitudes, making sure that if a young woman comes in asking for contraceptives, she's given those, and she's not told that she's too young and should stop having sex, because we know that that doesn't work. So we've done a lot of work around the staff attitudes, because we know that it's really the number one piece of the puzzle in our clinics. And in terms of capacity, we have assisted our facilities with kind of some extra clinical capacity through our technical assistance teams to help see young people, but also just move the queue in general in the clinics so that more time can be given to adolescents and young people. In terms of which activities led to improvement, we do have a few standards that we saw pretty dramatic increases in. One is the provision of IEC materials, information, education, and communication materials. The BeWise Mobi site, for example, really helped around that. Also, the implementation of the National Adolescent Health Policy helped address some of these standard areas. I'd be happy to speak to you more about it after the fact. And then finally, in terms of hospitals, that's a terrific question. Unfortunately, we still find that a lot of hospitals are kind of unchanged in their attitudes towards young people. We're working at PHCs because that's the entry level for young people. That's also where young people can access almost all of their HIV care and treatment. We have at 2 hospitals, one in each of our sub-districts, some special clinics for complicated adolescent HIV cases where they can get specialized friendly care, but that unfortunately is kind of as far as we've gone in the tertiary level. Okay.
Thank you,
Thank
Moira.
you.
Moira, you reminded us of a standards-based approach for adolescent-friendly services with both demand-side actions and service-side actions. But I like 2 particular elements here. One is you located a champion in all 30 facilities, and you also helped them after the training, mentored them, and also helped them to undertake quality improvement plans.
Yes.
So which is very good idea of continuously, incrementally improving the quality of services, and we have seen the results. So anyone who's interested in details can talk to her. Thank you, Moira, for your presentation. It's my pleasure now to invite the second speaker for this session, Ms. Arushi Singh. She will be presenting on assessment of adolescent and youth-friendly health services in East and Southern Africa, and she brings this experience from the Pleasure Project.
Sorry, yes, the Pleasure Project is one of the organizations that I volunteer for, but I'm an independent consultant otherwise on adolescent and sexual reproductive health. And this assessment was conducted for UNFPA and IPPF.
So you have 8 minutes, and you will hear a warning at 2 minutes. Right?
Okay, that's great, thank you. Thank you, everyone. So this was an assessment of adolescent and youth-friendly health services, which we conducted because of the Iaah commitment on increasing comprehensive sexuality education and youth-friendly services in the East and Southern Africa region. And what we did was we looked at the 8 WHO global standards which were released in 2015. So this assessment has been going on since 2015 and is just concluded in 2017. The 8 WHO global standards we looked at were adolescents' health literacy, community support, package of services, provider competencies, facility characteristics, equity, non-discrimination, data and quality improvement, and adolescents' participation. And we use this as the benchmark to assess the policies, standards, and guidelines of 23 countries. And we also did in-facility observations and interviews with health service providers and clients, and some focus group discussions in 12 countries. So in all, we visited 142 facilities across those 12 countries, and we spoke to 140 service providers and 964 young clients, and we spoke to a number of different key stakeholders, as well as peer educators, adult outreach workers, and young people who were not accessing the services to get some qualitative information. And so this is the status of the policies and standards and guidelines around adolescent and youth-friendly health services. As you can see, a number of the policies and strategies across those countries are fairly recent, which or some are being revised at the moment, some are under plan, being planned. And I think that a credit to the Iaah commitment goes to the fact that these are quite recent, because when we started in 2015, it looked like a very different table over there. For 4 countries, we didn't find any guidelines or standards, I should say. That was Comoros, Eritrea, Mauritius, and Seychelles. And just, Eritrea has been one country where it's been very difficult to find any information about health systems over there. So in terms of the findings, especially from those 12 countries where we really went in depth, and like I said, the national policies and the standards and the guidelines are quite progressive, and they're responding to the Iaah commitment. But as we've seen also with Maura's presentation, and from the plenary this morning, and from yesterday there was a session on the 10 to 14 Global Early Adolescence Study, the services on the ground don't always fully comply with the excellent policies that we have on paper. And this entire assessment confirms that. You have a situation where most of the 140 facilities we visited were actually integrated. They were not standalone. There were some standalone, but most of them were integrated facilities, providing youth-friendly health services within the existing health system, which meant that they had, for example, clean and friendly environments, but the focus on inclusivity and equity was not there. And those people who Gigi said this morning are hard to reach were still being hard to reach and not being reached. Typically, young people who are LGBT or young people who use drugs were not being reached, even though young people living with HIV were being reached. But that's because it was integrated health services, they were also providing HIV-related services, but we found, for example, supplies and commodities were lacking. You had a situation where half the facilities we went to didn't have ARVs. This is in a region where HIV is fairly prevalent. There's also very limited linkages between the outreach and the facilities. So a lot of the, about over 70% of the facilities had plans in place to do outreach, but only 59% had records of those outreach activities having taken place. So there's really, and when we spoke to the peer educators, to the adult outreach workers, it was clear that there was very fragmented linkages between them and the facility and their ability to send young people to those facilities. I have to say though, the young people, 964 clients that we spoke to, 73% of them were repeat clients, which meant that they were coming back and they were used to accessing those services. And in fact, we had a situation where 92% of them said that they were satisfied with the services. So that made us think, oh, it's great, everything's fantastic. But then when we were speaking to the peer educators, when we were speaking to the young people who were not accessing the facilities, we realized that privacy, respect, and confidentiality remain barriers. They don't want to go to those facilities because they are integrated, for example, and they'll be seen in the waiting area. They don't want to go there because they've heard of their friends or they themselves have been treated badly by the service providers. So these issues remain for those young people who are not accessing the services. The other difference between the clients who were already coming to the services and those who were not is that those young clients said they had support from their families and communities to access these services. While the young people who we spoke to who were not coming, they said, we have to hide, we don't know where to go. Our parents and community members would not be happy if I got pregnant, for example, and went to one of these health facilities. So they did not have that support. Sorry, 2 minutes, okay. I have to rush through the rest of this. And in terms of training, for example, a large number of the service providers we spoke to had received training on adolescent. When I say large, I mean about 60%. But it was for 7 days or 1 day, so it was not an ongoing, continuous, comprehensive training. Coming to recommendations, and we've sort of put those recommendations per the standards. I think what we're saying is you need to reach young people before they need services. We need to use the social media and the smartphones that we heard about also this morning, because a lot of the young people were in the clinics and they were on their phones. They were not looking at the IEC material available in the clinic. Most of them had heard about the facility from community, from family members and relatives and friends. They hadn't heard about it from outreach workers. So that level of community support building is still required, and providers need to be trained. In terms of data and quality improvement, 80%, more than 80% service providers are collecting disaggregated data based on age, sex, and services, but it's not being used at the national level to inform policies because the HMIS is not disaggregated. So these issues need to be addressed, and we still have, despite the progressive policies, we have laws that are creating barriers to access for young people. And that essentially is a very quick wrap-up of a very large study, and I think what we are trying to say is that in terms of health system strengthening, an adolescent responsive health system would be the vision to work towards. Thank you.
Thank you. And Arushi will not mind a couple of quick questions. If there are any questions, please raise your hands. Mike, please, on that side. One here and then one here, okay?
Hi. So those are really important things that you identified in quite vulnerable settings, and when we work in vulnerable settings, we still see that these are major issues. The problem, however, is that when recommendations are made, the next step isn't really carried out to implement those recommendations, and quite often the recommendations are just left hanging and things continue as the same. So I was just wondering if anything more is subsequently going to be done by all these organisations that you put up there to make sure that that's put into place.
So, you take another?
Yeah, sure.
Yes, please.
Yeah, my name is Renuka Motihar, and my question is around the whole integrated health services that you were talking about, and how young people, there was discomfort in it. So do you think that, from your assessment, what do you feel about the whole integrated versus standalone services, and what works better?
Do you have an example of somebody who did it really well?
Okay. So Arushi, you can please answer this. Two questions.
Yes, thank you. So in terms of next steps and how things are going to be implemented, because this was an initiative by UNFPA and IPPF, and it was in partnership with the regional economic committees in East and Southern Africa, there's been a lot of government support. We've gone to both government facilities, to NGO facilities, to private facilities as well. And within each country, at least the 12 countries where we did the in-country study, we had national validation meetings. In fact, the last one was just held earlier this week in Burundi. So there have been national validation meetings where the data has been presented to the government, and in some cases, because it's been going on since 2015, for example, Zimbabwe already developed guidelines once the data had been collected and they had preliminary findings. Similarly, Lesotho, we had the country validation meeting a couple of months ago, and a number of the recommendations that we were presenting had already been worked on, because we have been working closely with the government in those countries. And I think I can also ask Maya if she wants to add something in terms of next steps. But I'll just take the other question as well, in terms of integrated and standalone facilities. And I think it's really important to remember that there's no silver bullet, and it needs to be contextual. When it comes to young people, when it comes to adolescents, you need to understand who they are, where they are located, and what is it where are their rights being violated, and how do you sort of address those? And in some cases, for example, when it's vulnerable, marginalized groups like young LGBT, young people who use drugs, young people in sex work, you might need to have standalone services or specific non-traditional facilities that reach out to them, whether it's mobile services or through alternative service providers. But of course, we know that in terms of reaching the sort of the wider adolescent population, you do need to integrate. And I think one of the recommendations we are saying is pre-service training on adolescent sexuality for service providers. All service providers need to know how to address adolescent sexuality, because one of the things they told us was, we just don't feel comfortable in doing this. We don't feel comfortable in talking to young people about sexuality. So, yeah, I think that covers.
Thank you, Arushi, for addressing those questions. So, I have noted a couple of points. The beauty of this standards-based approach of service delivery is that then you can measure it. So therefore they went and measured probably the standards.
Yes.
And you used observations.
Yes.
You used exit interviews.
Yes.
And you also went into the field and talked to the potential clients.
Yeah.
So there are a lot of coverage challenges she has mentioned. Awareness alone may not lead to utilization because we still need community support structures and the gatekeepers' assistance to these adolescents who need services. And also, we have to build the confidence and trust of the potential clients as well. So thank you. So we have to be optimistic. You found changes happening.
Yes.
And we have given 50 years to immunization program. So let's wait and continue good things. Thank you so much.
Thank you very much. And we have preliminary findings, a research summary, if any of you want that. Thank you very much.
I would now like to call Ms. Tamara Zeberev. She's from University of Chile, and she's going to talk about transition from pediatric to adult healthcare services for adolescents with chronic diseases.
Thank you. Thank you. Well, the purpose of this presentation is to share guidelines developed by our research team in the Catholic University of Chile for the implementation of transition services for adolescents with chronic diseases from pediatric to adult health services according to needs assessment. So in Chile, 1 out of 10 adolescents has a chronic disease, as in other countries. 90% of them survive to adulthood. What happens in Chile is that an unplanned transition process leads to poor adherence to controls, to increased morbidity and mortality, and deterioration in the quality of life. Even there is an international consensus for transition services from the American Academy of Pediatrics, for the American Academy of Family Physicians, and the American College of Physicians. Transition services are in different stages of development worldwide. In Chile, we don't have policies, we don't have guidelines, we don't have transition services. Adolescents are transferred to adult services at age 15. Our team has a previous research line based on experience and perspectives from adolescents with chronic diseases, caregivers, and health providers about the transition process. The results of this previous research, when we used a mixed methodology, a mixed quantitative and qualitative methodology, we found critical points in transference. First, one, a substantial resistance to transference from adolescents, caregivers, and pediatric health professionals. Second, we found existence of a strong link between the provider, the adolescents, and the caregiver, and a fear of the adolescent and caregiver of being abandoned by the pediatric team. And third, a difficulty in developing autonomy and self-management and need of parental involvement and support in transition. These 3 points are very pronounced in our adolescents in Chile. It's a very special characteristics in our adolescents, especially the need of parental involvement, where there is a strong agreement between the adolescent, the caregiver. Fourth is the invisibility of adolescents. Healthcare is centered in the illness and not on the process of adolescence. And last one is the difficulty in coordination between pediatric and adult teams. So based on these 5 critical points, plus a review of the literature, especially the international experience, we define the objective of this presentation, that is to propose recommendations for the implementation of a gradual and planned transition process for adolescents with chronic disease from pediatric to adult care according to the detected